we're going to get a little bit more intricate. And here, this is also where we're going to talk a little bit about extension into the cartilage. There are many strategies. Currently at our place, we use dual energy to be able to identify the extension into cartilage. But let's just start with the gross extension and what we're looking for. So glottic and subglottic, here is the true chord, here is the lesion. And if it gets bigger, it can grow down this way to get towards the upper edge of the cricoid. And a standard vertical hemilaryngectomy will be taking it right here. But as I said, we almost never do open vertical hemilaryngectomies anymore. Most of what we do will still be through the endoscope. So there's the ventricle. Does it go this way to get along the inner surface of the cricoid, or can it go into the ventricle? I'll show you both. This is the typical, and here is the inferior extension. The first thing we try to do is say whether or not this will reach that upper edge of the cricoid. Remember, this is looks like a signet ring facing backwards. I might point out, looks a little bit like the Patriots Super Bowl ring, but I digress. So we'll mention some other things. But it comes way up higher in the back than it does in the front. So here is the cricoretinoid joint, and here is that edge that becomes our key landmark. So simply put, if you see tumor along that inner surface, it's gone too low. It's below the upper edge. Here's the cricoid, here's the cortex. So if you saw this knuckle of tumor, it would be right about down here. So obviously they wouldn't be able to make an incision to take this particular tumor out without taking a significant part of the cricoid. There are strategies. They can actually use cadaver aortic grafts to do that, but it's not done in many places. So here is tumor along the inner cortex. Now, also, when you're at the anterior commissure, that's part of the glottic subglottic region. It's where the cords come together, stitch themselves into the thyroid cartilage. Tumor can go into, remember the mucosa is very close to the cortex, so tumor can go into the thyroid cartilage, can go into and through. Also, if it's in the region of the anterior commissure, it can squeeze out between the thyroid and cricoid cartilage. There, you think of there being a cricothyroid membrane, but in most cases it's actually incomplete, and tumor can grow out through this. That little knuckle of tumor, you can see it growing out, that little knuckle of tumor is enough to change the staging. This now is extralaryngeal. The prognosis is different, the treatment is different. So how do we find it? Well, there's almost always a little bit of fat, if you look for it, right in that gap. And so if the tumor goes through, it will obliterate that fat, so we should be able to detect it. So look for cartilage extension, and also look for tumor squeezing between the thyroid cartilage and the cricoid. So now we put the tumor right here, and we talked about it extending down like such. We're going to now briefly talk about really one of the most important concepts. That's the paraglottic space. It's a bad term because it's not just right at the glottis, it's all of this soft tissue. There's a man named Harvey Tucker that did the initial descriptions of this, and he included the thyroretinoid as part of that. So here is the soft tissue. Let me make a point. If you have a tumor that's supraglottic, to get into it, to get into the paraglottic space, and then have no real resistance to up and down spread, the tumor has to go through a fascial layer called the quadrangular membrane, right here, okay? I think I have, there we go. So here, it would have to work to go through. If it's below the edge of the cord, it has to go through the conus elasticus, all right? That's work too. But if it's right at the ventricle, you can have growth go through this area. And this has become a very important concept when you're trying to do endoscopic partial resections or endoscopic partial laryngeal resections. Obviously, you want to take as much of the tumor as you can. In fact, you want to take all of it. Couple of points. It's limited by the thyroid cartilage, but again, tumor can escape this way. All right, we're going to go here and we're going to put a little tumor on the edge of the cord. What are its options? All right, here it can grow down or it can grow right into, and we're seeing more and more of these cases, it will go into the ventricle. Why is this important? When they look in, they'll see a nice intact mucosa comes right down to the ventricle. They may see a little bit of a lesion, but they may not be able to really judge how much tumor is there. And if you're going to take this out endoscopically, then that's a major consideration. So the tumor can spread. It may actually look as though there's filling, a big submucosal mass. As this gets bigger, it may interfere with the cord motion, so-called fixed cord. It may also be a route to go extra laryngeal one more time. So what does that look like? Well, here, by the way, is that little gap. All right, here is what that looks like to us, but to the clinician, they look in and all they appreciate is a relatively small lesion. And here's what it looks like on the CT. Here, you can see this is the mucosa. We're at what level here? We're at the level of the supraglottis, getting down to the arytenoid, but we'd be right about up at this level. And the tumor is filling that space like so, but here is the mucosa. So this is all out of the view. Notice it's coming back between the arytenoid, thyroid cartilage, and we'll show you that in just a second. But as we follow this down, now we're at the level of the true cord. Here's the arytenoid, cricoarytenoid joint. Here we don't see good separation. We'd like to have gotten the tumor to light up a little bit more, but we know it's there because of the bulk. And then you follow it down into the subglottis. Even here, it's actually, when they looked in, they could see a nice smooth mucosa. And here, all this bulk, and here a little bit of early extension, which really makes all the difference in the world. This patient was not, as I'll show you in a minute, a candidate for an endoscopic resection. We follow it down, and here we're down at the level of the cricoid again. All right, here we've dissected this out a little bit. You have the arytenoid, the cricoid, and here is the vocal ligament, if you will. There is one blind spot. You know, the ventricle is what we've always talked about, upper edge of the cricoid. But if you have people that do a lot of endoscopic surgery, the posterior paraglottic space right back here, we showed you that the tumor's going between arytenoid and thyroid cartilage. This is almost impossible to get to endoscopically. You'd have to take the arytenoid off and you'd be looking back into this area. So this has become a major landmark when we're looking at these things, when our surgeon wants to do this type of surgery. This patient would not have really been a great candidate, so they would have gotten radiation chemotherapy. Now, what about the cartilage? The cartilage, we said, can be involved in two sets of lesions. Supraglottic? No. If it's totally supraglottic, it almost never will go into cartilage. I've seen one case. If it is glottic, it can go into the cartilage. If it is transglottic, crossing from the false cord to the true cord, as soon as it hits the true cord, then it can go into the cartilage. Then you have to look. So what are our indicators that tumor is going into the cartilage? Well, this is the one that we've always used, and this is still the best. If you see tumor on the outside of the cartilage, then you know that the cartilage had to be involved. That's not a whole lot of thought with that. If it's on the other side, must have gone through. So that indeed is the best indicator. But what about this? Well, the tumor here is really nowhere near this. This looks even more destructive, if you will, but this is totally normal cartilage. What it is non-ossified. So it just, you have ossified cartilage or non-ossified cartilage. Now, another thing, one of the things, tumor never or virtually never goes into non-ossified cartilage. Why not? Nobody knows. Non-ossified cartilage has really no blood supply and is very resistant to tumor invasion. Now, if you have a huge tumor that eats everything, maybe, but non-ossified and ossified cartilage, we want to look for tumor, and here the tumor was going into the cricoid, so we're able to see it, but this was normal. Sclerosis of the cartilage, I should mention. We don't know exactly what that means, but it's another parameter we mention when people are doing radiation chemotherapy. But let's look at the standard image of tumor going into the cartilage. Here are the choices. I apologize for having such a busy slide, but these are essentially surface coil images, if you will, of the larynx. And here is a tumor. This is most of the bulk of the tumor, but is it going into the cartilage? It turns out it is going into the cartilage here. But what else can we have? You can have ossified cartilage and non-ossified cartilage. And this is how it behaves, but we're just going to summarize and move on because we don't really do this often. Here, you've got fat. Fat is our friend. Tumor never looks like fat. So as long as you see fat on the T1, you're done. That doesn't have tumor in it. Here, you have non-ossified cartilage. A lot of proteoglycans, things like that. But here's what it does. If it looks sort of intermediate on the T1, it looks the same as tumor. You do a fat-suppressed T2, and it usually will get darker, but it will be different at least from the tumor. All right, and then it will not enhance. So those are the normal findings. Here, this is tumor grossly going into the cartilage, and this is just secondary edema. Remember, squamous cell cancer has, in many cases, a small inflammatory margin. So the tumor may have some inflammatory component, and you may be able to see it. So here, this is actual tumor. And it's sort of intermediate in enhancement over here. So it follows the basic characteristics of the tumor. Here on the T2 with fat suppression, this is sort of the evil gray that we talk about. Sort of an intermediate signal, not quite as black as the normal, but it's about the same as the tumor is here. Here, the thyroid cartilage, this is probably edema. Now, we presume that it carries some cells with it, and so that fits into the description. But once it has cartilage invasion, they usually don't do endoscopic resections. So, all right, those are the tissues that we have, but we're now going to go to CT. Why are we going to CT? It's because here, this patient held very still. We had very nice imaging. But most of these patients, it's essentially, they have a very limited airway. They're not going to hold still. These are about the best images that I have of this phenomenon. So we're now using dual energy. Now, why is that? Well, dual energy is pretty good at being able to separate some types of densities from other. And particularly, it's great at identifying iodine. All right, what does that look like? Well, here are various virtual monoenergetic images. This is one scan with a dual energy CT. There are many different ways to do it. Ours is rapid KVP switching, but again, that depends on the vendor. But this is the basic principle. By dialing this up at 45 keV, Now, this is not the energy. This isn't KVP. This is actually KEV. The contrast in the tumor and the cartilage look exactly the same. When you get to the higher level, the contrast in the tumor and in the jugular start to fade out, whereas the non-ossified cartilage is white. Now remember, we just said the tumor doesn't go into non-ossified cartilage, it goes into the ossified part. But the difficulty at making the differentiation is being able to say which is which. So even though it isn't going to go into the cartilage, they're going to look the same, and we want to separate them out. Now here's a diagram of dual energy CT. This is 40 keV and this is 140. So what have we done? All right, here we've actually done some regions of interest, different levels. And here is the edge of the tumor. So if we want to accentuate the edge of a tumor, pick up the iodine a little bit better, then we're going to use the low KEV. But if we want to see the cartilage without the enhancement, so look how different that is. Now you can say that's non-ossified cartilage and not tumor. Here you wouldn't be able to do that. So here's the diagram that we go through. This is iodine, and notice you start up, this is cartilage, and this is the iodine map, if you will. So at this point, the low KEVs, remember, usually what we're looking at is 60, 70, you're not able to separate them out. On the higher KEV, virtual KEV these are, they separate out very nicely. Cartilage is going to be white, and the non-ossified cartilage is white, but the tumor will not show, because what you're actually looking at, the density here is because of iodine. All right, so let's see how we can make that happen. Remember, tumor won't go into non-ossified cartilage, but that's the differentiation. So here is a set of images that we've actually tried to dial in both the iodine and anything that has a blood supply. Remember, this is proteoglycans. There's not really any blood supply, so no iodine. So here's the tumor, here's the non-ossified cartilage, and as we go through this all the way to the top, you basically can make the designation. So this is non-ossified. Now, non-ossified cartilage, that makes a difference, because if tumor goes into the cartilage, it'll change the possibilities of surgery, it'll change the prognosis of radiation chemotherapy. So we follow this down, goes quite a ways. Here is the tumor, and so that is the end of section 2, and thank you for your time and attention.